Hey everyone, welcome to ABC's Anesthesia. Now, today I've got Megan, and we're going to do another practice Viva. So this is going out on YouTube, which I'll have to cut short. And when we're about to start the discussion of the Viva, that all will be in the full video on the final exam course, and I'll have a link to that as well. So, big welcome, Megan. Thanks so much for your time to be examined live. How do you feel?
Oh, a bit nervous. It's not every day that you get filmed doing a Viva, so but I think it'll be good.
No, it absolutely will be good. And it's just one of those things where if you have a bit of stress, you just learn stuff better as well. And I'll, give you all these notes and everything to go home and study. Have you had lots of Vivas? Is there any particular feedback and things you want to work on?
I think this is, so we're 4 weeks out from the exam, so I think this is number 38-ish.
Good.
I've been counting them to motivate myself to keep doing them. Yeah, I think just working on those like competing priorities, like you talk about in the course, I think would be really great. Like when you've got sort of 2 things you want to be doing at the same time, but you can't, or when there's sort of like no one right answer and you want to sort of talk about why you've chosen to do what you're going to do. I think would be great if we could work on that.
Great. Yeah. In real life, the only wrong answer is no answer often. Like you got to do something, right? And I think this exam, like for anyone who doesn't know, like this exam really does feel like real life. Like nothing's perfect. You have to make compromises. You have to choose choose out of a bad bunch of options, but plan for the difficulty. And I think it's a really, really awesome way of actually preparing for real life. And I got a lot out of this exam. There's many reasons what I didn't get a lot out of the exam, but this is, I feel like the Viva was definitely a good real life version of what we do. So Megan, I'm just going to share the screen with you, and for everyone, I'll just read out the STEM, and then we'll give you some time to work through it. So the STEM is you're on the night shift at your tertiary hospital. You are called to the resus bay in emergency as a 55-year-old male presents to emergency with severe respiratory distress. You arrive to see a patient with high-flow nasal oxygen, such as an optiflow thrive, looking unwell with labored irregular breathing, sats 92%, unable to speak due to respiratory distress. What do you do when you arrive as the doctor leading the resus? Take however long you need, maybe 1 to 2 minutes to write down your notes and get your thoughts into gear, and then we'll go to you in a few seconds. Okay, Megan, so in that time, what did you do? Like, what did you write down on your piece of paper?
So I mean, I can hold it up, but my handwriting is pretty terrible. So
that's right. You can guide us through. Yeah.
I might just read it to you. So I wrote down tertiary hospital, ED, 55-year-old man, stats of 92, respiratory distress. And then I spent some time about thinking about my opening statement. And have to tell you now, or?
Yeah, actually, why don't we crack on? So, candidate 234, what do you do when you arrive? Do you understand the question?
Yes, I do.
Great. What do you do when you arrive as the doctor leading the resus?
So this is a critically unwell middle-aged man with signs and symptoms of severe respiratory distress, and the possibility of impending respiratory arrest needs to be considered. I would attend immediately. There are clinical and logistic considerations here. Logistically, I would attend immediately, introduce myself to the team as quickly as possible, and assign roles. Clinically, I would get a targeted history from the patient or any attending family members if possible, and conduct an A to E assessment with the aims of creating a differential diagnosis list in order to target specific treatment. In terms of my A to E assessment on airway, I would assess the patency, threats to patency, anatomy and physiology of this man's airway. In terms of breathing, I would assess his efficacy and the effect of hypoxia on his end organs. I would consider instilling BiPAP immediately, given he seems to be not thriving on high-flow nasopharynx. I would assess his cardiovascular status by assessing his vitals and conducting a targeted cardiovascular exam. In terms of disability, I would assess his GCS. And in terms of PED, I would expose him and consider adjuncts to my assessment, which available in the GVA may be a mobile chest X-ray, a POCUS TTE, and an ABG.
What was that? A focused what, sorry?
Echocardiogram TTE.
Okay, good. So let's say you arrive to see the patient, you know the numbers, the cardiovascular side of things, the patient's heart rate is 120. It looks like sinus rhythm on the monitor. Blood pressure is 130 on 80. Definitely looks like the patient's in respiratory distress. What was your breathing assessment specifically?
The effort, efficacy, and the end organ effects of hypoxia.
Yeah, so you don't really see too much from the end organ point of view. How do you assess the efficacy?
So that would be a gross assessment of the saturations. as well as his ability to speak in sentences, in words, and his ability to comply with a standard cardiovascular examination, which will include auscultation of his chest and hopefully a mobile chest X-ray.
Let's say you listen to the lungs and just you can hear normal air entry on both sides, but respiratory is rapid. That's 92%. You've got the high flow in. There's a lot of noise around the room. The effort of breathing looks labored and irregular as well. It looks like the patient's really struggling to breathe. How else can you assess breathing?
So if the chest air entry, if the air entry sounds normal and there's no wheeze or crepitations, then I'd be wanting to consider. I'd be wanting to tailor my airway assessment to the cause of this man's respiratory distress, which would be the patency, any stridor, dysphonia, dysphagia, drooling, tripoding, sitting up, sitting forward. My standard obstructed airway assessment.
Good. And let's say you do that and the patient's definitely sitting forward, looks like they're struggling. They aren't particularly drooling, but you can hear some stridorous noises. You do get a chest X-ray immediately, and you see that they've got a sternotomy scar there, and it looks recent when you check the chest. So you are able to receive a past history from the patient's brother, so type 2 diabetic, hypertension. They had a big operation last week, and all you see is that sternotomy scar, but the patient's unable to tell you anything. There's no collaborative history. All he knows is he's had a big operation. There's no history of any lung issues that he said. Patient's meds are metformin, atorvastatin, and apparently has an allergy to Sugamidex. What else do you want to know on assessment, and what are you most concerned about in this situation?
So on assessment, I'd want to know the indication and exact operation that was performed. I want to know for any immediate postoperative complications when this man underwent his sternotomy and where that sternotomy was conducted. If it was in my local hospital, obviously that's great. I can access the records. And then but in terms of what I'm most concerned about, I'm most concerned that this is a significant complication of the procedure that this man has undergone, which is obviously major thoracic surgery. And in the immediate sense, I'd be thinking about pericardial tamponade. He's had, for example, a coronary bypass surgery, a kinking of one of those vessels and significant ischemia. I'm concerned about hemothorax and pneumothorax. Those are the ones that are bring to mind. Yeah,
great. So you do get a TTE, and there's no signs of any cardiac compromise, just a hypercontractile, like this, a very sympathetically charged patient. Volume status looks fine. There's no valve issues at all on TTE. And on chest X-ray, you don't see any effusions at all. You do manage to get some notes, and there is mention of thymectomy. What do you think of that, and what do you do?
So in a 55-year-old man, that makes me think about the possibility that he's got myasthenia gravis, which would explain this presentation. I note that myasthenia gravis has a bimodal incidence, with initially women below the ages of 30 and men over the ages of 50, and that thymectomy is often a therapeutic intervention to hopefully improve myasthenic control or achieve remission. So I'm now thinking that this is a primary respiratory failure in the setting of neuromuscular weakness.
Okay. And let's say, what would you do to try to, confirm that or to treat this patient's problem?
So sorry, just to put a name to it, I think this is myasthenic crisis. Sorry, with those keywords. So in terms of confirming that, I think history examination investigation again. Our history is consistent with that. I'd be looking to ask this man if he has myasthenia gravis. I'd be looking at what treatment he has been on since his thymectomy. If there was improvement of his symptoms, if he's been compliant with his treatment recently, and so that may include pyridostigmine, it may include steroids, or if he's missed any of his treatments, if he's noted that he's more weak, I'd be looking to see if he's got ptosis as well, to me confirmatory of what's going on. And then other factors on examination would be global weakness, such as axial weakness or limb weakness.
That's a great assessment. He definitely confirms by nodding that he has myasthenia gravis, and you're able to get some final collaborative history. He has had the disease for about 6 years. He was on pyridostigmine at about 500 milligrams per day in total dosing. You can definitely see ptosis. He definitely has a weakness of his muscles at this point, from what you can grossly look at. What do you do now in this patient?
So the treatment for a myasthenic crisis is pyridostigmine or other anticholinesterase. But ultimately, I think this man requires intubation and ventilation whilst we establish plasmapheresis or IVIG in order to achieve to achieve control of his myasthenic crisis, because those treatments will probably take more time to take effect than he has in light of his significant respiratory compromise.
Yeah, so while you're trying to get that in place and get all the gear for intubation, what would you give?
What would I give?
Yeah.
So he's on 500 milligrams a day of pyridostigmine.
And he hasn't taken that. Sorry, he's been non-compliant. He thought the thymectomy was curative. And, sorry, we got to mention that.
Yeah, so I would convert his pyridostigmine dose into a neostigmine dose. And I'm just trying to remember what that is. I think it's 30 milligrams of pyridostigmine equals 1 milligram of neostigmine. So I would consider giving him a dose of that, taking into account that I still think this man is going to require intubation and ventilation, and not giving him his neostigmine may actually make that process simpler in terms of dosing of neuromuscular blocking drugs and safe transport to ICU.
Okay. Let's say you do give some neostigmine and he does get resolution of his symptoms, and therefore you've got a bit more time at this point. Tell me, how do you classify myasthenia gravis?
So it can be classified according to the etiology, but in terms of the severity, the Osman-Jenkins classification system, also known as the Myasthenia Gravis American Foundation of Classification, I think. It's a 1 to 5 scale, with 1 being mild weakness of the ocular muscles only, 5 being requirement for intubation and ventilation, and categories 2, 3, and 4 having subcategories A and B each, which is according to whether there is ocular weakness primarily, or ocular and vulvar or respiratory weakness primarily, or axial limb weakness.
Okay, that's good. So let's say this current crisis resolves completely. The patient goes home, has a lovely life, is now on kind of myasthenia gravis management and treatment, doesn't have a thymus anymore, and that was done. Now the same patient presents 3 years later, and they present with a small bowel obstruction. Surgeons have assessed a small bowel obstruction, presumably due to some level of adhesions from a previous operation, for let's say a hernia, and now they're scheduled for a laparotomy. What do you want to know on assessment?
So I break this down into assessment of the small bowel obstruction and assessment of the myasthenia gravis. And I break each of those categories down into the history, examination, investigation. So in terms of the small bowel obstruction, I would like to know the duration of the small bowel obstruction, the severity of his pain, and whether there's been any signs or symptoms of perforation, and associated with that any signs or symptoms of sepsis or septic shock, as well as an assessment of his volume with an electrolyte and acid-base status. In terms of his myasthenia gravis, I would want to know his Osman-Jenkins classification grading in terms of the severity of his symptoms in a day-to-day time, his current treatment, and when he was last able to take that, and when it's likely that he was last able to absorb that PO. The treatment he's on, I would classify it into whether he's on pyridostigmine or another anticholinesterase, whether he's on antimuscarinic therapy, how effective that is, whether he's also on immunosuppression, whether that's steroid-based or non-steroid-based, such as azathioprine, any complications related to that, and his requirement for IVIG or plasmapheresis, and if so, when that was last given. I'd want to classify whether his weakness was primarily respiratory and vulvar, or axial and limb. All these things would inform my management of this patient and their small bowel obstruction. Yeah.
What else do you want to know about the patient as they come into? I guess you're either when you review them in emergency or when they come to see you. What else for the smaller bowel obstruction do you want to know?
So I'd like to know what fluid resuscitation they have had, the location and extent of the likely small bowel obstruction, any perforation, as I mentioned before, what access they currently have in situ, and whether someone's put a nasogastric in, and whether their stomach has been decompressed. Which will give me an idea of the urgency of the management of the small bowel obstruction. I'd also want to know a full anaesthetic history.
Good. Let's say I'm going to give you some information now. Actually, besides that, for myasthenia gravis, is there any other organ involvement that would be particularly interesting for you?
Yes, myasthenia gravis patients can have cardiac antibodies, classically against the beta-1, beta-2 receptors and the orionogene receptor, which can result in significant arrhythmias, myocarditis, and cardiac failure. This can cause autonomic instability as well.
Okay, good. There's no signs of any cardiac involvement. ECG looks pretty normal with occasional atrial ectopics. Patient is sinus tachy. So you've done doctor's diabetes kind of assessment of the patient's state currently. They've had 2 liters of resus, afebrile, blood pressure is 100 on 50, 120 on 50, and they've got an outline in situ from being in emergency. They've been resuscitated. They look stable enough to go ahead. Myasthenia gravis, so let's say they're class 2, let's say class 3. They've got on their regular pyridostigmine of about 500 per day. They're on 10 milligram of prednisolone, 6 years I mentioned, but now +3, so it's 9 years since the diagnosis. What's your anesthetic plan for this patient?
So my anesthetic plan for this patient, I would break down into preparation intraoperatively and postoperatively, including disposition. In terms of preparation, I'd be wanting to conduct a rapid sequence induction, and I'd be wanting to do that with a skilled anesthetic nurse, and with monitoring available. The additional monitoring, in addition to the standard aspirin monitoring that I would want, would be an arterial line, which I know this patient already has, a 5-lead ECG, a BIS, a temperature probe, and an IDC. I'd conduct a rapid sequence intubation. Now, the use of neuromuscular blocking agents in myasthenia gravis, we're aware, is controversial. Noting that this patient will be have approximately 2.9 times the ED95 for depolarizing agent and require approximately only 10% of the standard dose for a non-depolarizing agent, which is typically the choice. But I know that this patient is also allergic to Cigavidex. I'd be interested to know exactly what that allergy is.
Yep. Let's say it's anaphylaxis.
Yeah, okay. But in this patient, given that my goal is to achieve rapid control and securement of this patient's airway, avoiding aspiration, after placement of a wide bore orogastric or nasogastric tube and suctioning of that, I would elect to use succinylcholine at 2.9 times the standard dose.
The 2.9 number, where's that from?
I actually can't remember the source, sorry.
That's right.
I think that, yeah, sorry.
That's fine. Higher dose. And so what is this dilemma? Like, what's this? You mentioned you need 10% of non-depolarizer. What's the implication of you using sucks now at a higher dose?
So the implication is potentially greater side effects in terms of cardiovascular side effects, but also unpredictable duration of blockade, which could make surgical conditions more difficult. I would also say, I would use the Liebenthal criteria to consider this, but I would also say that a prolonged neuromuscular block is potentially not overly problematic in the sense that this is a patient I'm extremely unlikely to be extubating at the end of the case. It's very to go to ICU just because of the severity of his disease and the fact that he's having a major body cavity surgery. He's having a laparotomy.
Okay. Would you ever thought of doing any other technique without using muscle relaxant?
Yeah, so I guess there's sort of broadly speaking 3 options. So there's the 2 that I've already discussed, and then avoiding neuromuscular blocking drugs altogether, which in my hands would involve induction using a bolus of remifentanil, and some lignocaine as well, noting that lignocaine is broadly considered safe in myasthenia gravis patients, although can worsen neuromuscular function.
And what other drugs, generally speaking, can worsen muscle function that you want to avoid?
Yeah, so there are a number. Broadly speaking, these can be broken down into those that affect presynaptic, synaptic, and postsynaptic function. But some common ones that are often discussed, just to avoid listing everything, would be beta blockers and glycosides, local anesthetics.
Yeah, okay, good. So let's say whatever you do, you are forced to give muscle relaxation. And let's say you've already given succinylcholine, but let's say for whatever, it has worn off now, and the surgeon requires more relaxation. What do you do?
Yeah, so this would be a discussion with the surgeon, and I think would be informed by whether I was planning on extubating this patient or not. Given the reasons that we already discussed and the fact that I'm not planning on extubating this patient, I'd be happy to give a very small dose of rocuronium, noting that this does likely commit us to keeping this patient intubated and transferred to ICU.
Yeah, good. Let's say, just for argument's sake, if you were to, for whatever reason, need to reverse this patient, what would you do?
So, given they've had anaphylaxis to Cigavidex, our options remain glycopyrrolate and neostigmine, which need to be considered in the context of the fact that this patient is on pyridostigmine and we want to avoid precipitating a cholinergic crisis. So I think the safest thing to do in this patient would be to simply wait and allow time while optimizing all conditions for metabolism or excretion to occur. But in, say, a more elective patient who is allergic to Sugammadex, that would need to be sort of weighed and considered in light of say, a planned extubation.
Let's say you hand over the case to someone, to one of your registrars, you're about to go home, and for whatever odd reason, your registrar now reverses the patient because the surgeon or the ICU said they've got no beds, and for whatever reason, they said, look, let's give it a go at reversing. You see an alarm call as you're in the change room, about to get ready to go home, and you rush in to see that the heart rate is 10. What do you do?
So a heart rate of 10, I would ask the surgeon to stop, scan the monitors, examine whether this was a sinus bradycardia or another rhythm, such as a heart block. Most likely the treatment that needs to be given for this patient is 600 micrograms of atropine, and I think that this is a cholinergic crisis, which should...
What is a cholinergic crisis?
So a cholinergic crisis is a manifestation of excess acetylcholine in the synapse, which typically causes bradycardia, bronchuria, bronchospasm, and then all the sludge kind of things as well. So salivation, urination, lacrimation, diarrhea, increased peristalsis.
Great. So let's say you give the atropine, and in spite of giving the atropine 600 mics, but the heart rate is still 10, and you see a rhythm, and it looks like the patient's actually in heart block, a third-degree heart block. What do you do?
So this is extremely concerning. I would press the buzzer to call for help. I would temporize by considering another bolus of atropine or making sure that my first bolus has gone through the line. I would ask for transcutaneous pacing to be set up as soon as possible, and for a senior anaesthetic nurse to prepare an infusion of isopropyl.
Yep. While you're getting the transcutaneous pacing, you give atropine. The heart rate is still 10. The blood pressure on the outline reads at 50. What else can you do?
So if the blood pressure is 50, that's my threshold for CPR. So I would commence CPR according to the ALS algorithm.
Okay. Tell me what you do.
So in instituting the ALS algorithm, I would declare that this is an arrest. Ask probably the surgeons to commence CPR at a rate of 100 to 120 compressions per minute. I would ask for a rapid rhythm check, noting that we've had an ECG on, but that could have changed in the last few seconds. And that rhythm check will either push us down the shockable and non-shockable algorithm. Let's
say that on the rhythm check, you do see that it is the same bradycardia 10 heart block, complete heart block.
So this is a PEA arrest, and therefore we're down the non-shockable algorithm. I would dump the shock according to the coached algorithm and administer a milligram of adrenaline before proceeding with another 2 minutes of CPR and considering my 4 H's and 4 T's.
Good. You managed to get a heart rate up to 20. It's still complete heart block. The pacer arrives. The defib arrives immediately. How do you institute transcutaneous pacing?
Yeah, so I would, the position of the pads would be the same position that I would imagine we had for CPR, which is one on the pericardium and one in the axilla. The defib needs to be changed into a synced mode, which I would do immediately, and then I would slowly up titrate.
What do you mean by sync mode?
So that is the administration of the electricity synced to the ECG.
This pacing rate, right?
Yeah. Have I misspoken?
You may be thinking of synchronized defib of rapid AF.
I'm sorry. Yes.
No, it's fine.
I did misspeak. The pressure of the recording. And so then I would increase the millivolt up until, so I change it to pacing mode. I would increase the millivolt threshold up until we achieve capture. I would confirm capture both electronically and mechanically by feeling the pulse. And then I would go 10 to 20 millivolts above where we achieved capture. In this patient who has had likely cholinergic crisis, but it could have underlying cardiac disease, I'd also be looking to inform my cardiology colleagues of this case to consider transvenous pacing. Beautiful.
Hey, we'll end it there. That was great, Megan. Fantastic. So what I'll do is, hey, so for everyone on YouTube, we'll end the Viva there. So I'll put a link up to the final exam course, but I'll put the full feedback as well for the Viva. So yeah, that's where we'll get it at. And Yeah, good. So, now what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.